people who have joined us, and I would like to recognize them. I want to recognize the CEC from Kisumu County, Professor Boaz Otieno. Kindly wave at us. Thank you very much for coming all the way from Kisumu. I also want to recognize the consultant. When we were doing this work, when we started last year, he worked very closely with us. Dr. Mwai, kindly wave at us. Thank you very much. So we are doing very well. I want to move to the next activity. And the next activity, Madam CAS, we are going to have Dr. Gladwell Gabecha give us the overview of the strategic plan. Karibu Daktari.
Thank you, Madam CS. All protocols observed. Good morning to all of you. So I'm here today to take us through the strategic plan so that we can get the key highlights of what is entailed on it. I hope the presentation is being shown on the screen. Okay, we can move to the next slide, please. Okay, I'll begin my presentation with this pictorial representation, which is just depicting why we are here today. If you can look at this individual, he's managed to have all the risk factors going on for him. There's tobacco use, there's alcohol use, there's a sedentary lifestyle, and there's also unhealthy diet. But I want you to pay close attention to what is written in his t-shirt. That is, free to be me. This statement is partially true, and partially the reason we are here. It's the responsibility of government and stakeholders to ensure that it is easier for individuals to have or to make healthier choices. Situation. Currently in Kenya, most of 39% of the people are dying as a result of a non-communicable disease. When you look at the hospital mortality, this is actually way higher at 42%. Cardiovascular diseases is the highest cause of mortality among the NCD groups, and it's responsible for 12% of all the deaths. When you look at cancer, each year approximately 42 Kenyans are dying as a result of cancer, where the new cases that are being diagnosed annually are approximately 27%. For diabetes, we have estimated 2% of the Kenyans currently living with diabetes, where injuries, which is also an NCD, is responsible for 7% of the mortality. Next slide, please. So all these NCDs are being driven by risk factors, as I depicted in the first slide, and these are some of the statistics we have for the risk factor profile. For obesity, we have 19% of Kenyans being overweight, where 9% of them are obese. When we look at both of them, obesity and overweight, the women lead and are actually at twice as much, with 38% compared to the men at 17%. For high blood pressure or hypertension, we have a quarter of Kenyans having hypertension at 23%. For tobacco use, we have a figure of 13.3%, and again here the men lead at 23%. Almost a quarter use tobacco in any form, be it smoking, or the newest being shisha or the lift, one of the new markets in the products. Females are actually at 4%, but this is not a good figure because when we look at it 2 or 4 years back, it was much lower at 2%, so they are catching up with their male counterparts. For alcohol use, we say that approximately 20% of Kenyans are current drinkers, but now the most worrying part is the heavy episodic drinking, which is the consumption of 6 or more drinks in one sitting, and it's more responsible for more risk of NCDs. This we say that we have 12% Kenyans engaging in this heavy episodic drinking. For physical inactivity, we have approximately 6.5 Kenyans being physically inactive. No, just move behind. We have to be alive to the fact that there is an epidemiological transition, and the former pattern of NCD is changing. And one of the things I want to highlight is the pie chart on my left. So contrary to what has been shown in the past, NCDs are now affecting the younger population more. As the pie chart is depicting, we have around 53% of the burden, that is death and disability, happening to individuals who are younger than 40 years. And also the other graph, it's showing that contrary again to what was thought of the past, we have NCDs now affecting the poorest population. It's not longer a disease of the wealthy. It's now affecting also the poorest. The yellow bars shows the crude death rates from NCDs. The first bar graph is the one for the poorest population, while the one on the extreme is the one for the richest. And you can see that the crude rate is 130 among the poorest, and it's actually half among the richest. So as we move forward and we engage in NCD programming, we have to take care of those changing demographics that is affecting the younger people more, and it's also affecting the poorest. It's no longer a disease of the lifestyle of the wealthiest among the population. We can move on. This is the risk factors I talked about, so you can move on. I want to demonstrate the process that led us here. I think both Anne and Dr. Murray alluded to how we got there. We had a strategic plan, and at the end of it all, we did an evaluation. That is towards the end of last year. Some of the evaluation findings is that we found that the objectives and activities were really too many for that duration. There were a total of 109 of them. We also didn't have a costed strategy, so resource mobilization again was a bit difficult. The strategy lacked targets, so for especially the process indicators. We didn't know whether at the end of the 5 years, did we perform good, did we perform fairly okay. We were not able to determine this because we lacked targets. We also, management of NCDs was not heavily emphasized in the previous strategic plan. And also the management of NCDs, both prevention and also in adolescents, was also not well addressed in the previous strategic plan. So overall, we were able to fully achieve 17% of all the activities. Then we also just partially achieved 68%, where we did not achieve in 13% of the activities. We can move on to the next one. At the end of it all, we said we still have to forge ahead. We have lessons we have learned, and that's why we decided that we still need a strategic plan for the next five years. First of all, we need to provide guidance for all the stakeholders that are involved in NCD programming. NCDs, as I demonstrated below, continues to be a public health concern. If nothing much is done, it's actually projected to overtake communicable diseases in the years to come. Also, investing in NCDs has been proven to contribute to reduced health care costs and increase economic development. And also, if we implement a strategic plan, we'll be able to achieve some of our global commitments. For example, the SDGs and the Global Action Plan for NCDs. And then closer home, we'll be able also to achieve the Vision 2030. And lastly, we learned from our lessons of the previous strategic plans, and now we forge our ways to ensure that the gaps and recommendations are put in place. Next slide, please. So for this new strategic plan, we are guided by a vision, and our vision is we want a nation free from preventable burden of NCDs. And I use the word preventable because there is that avoidable burden due to genetics that we cannot get rid of. Next is our mission statement. It's quite mouthy and lengthy, but the spirit behind it is that we want to ensure that we are taking care of all life cohorts. We want to ensure that there's an aspect of universal health coverage, and at the end of it all, we want to alleviate both the disability, the new cases, the deaths, to ensure that we have productive Kenyans who are able also to contribute economically to the economy and the country. And then for the goal, we mirrored the global goal for NCDs, and we want to ensure that there is reduction by a third premature mortality due to NCDs by 2025. So that's the goal of the strategic plan. We can move on. Next slide. So we do have some guiding principles that lay the foundation for this strategic plan. There are 11 of them. We want to emphasize that equity, universal coverage, right-based approach, multi-sectoral approach, evidence-based approach, life course approach, people-centered approach, primary healthcare approach, integrity and accountability, gender responsiveness approach, innovation and technology are what are the drivers behind what we'll implement in this strategic plan. So trying to ensure that everything is done to be all-inclusive and also moving with the times, and we are ensuring that we're also basing our activities and implementation on scientific backing. We move on next. So for the scope, you might be aware that when you talk about NCDs, we have a multitude of these diseases, but in order to focus our activities or resources, we decided to choose some conditions that have the greatest burden within our country. And the ones projected now in the screens are the ones we chose. Not that we neglect other smaller, and I say smaller in quotes, NCDs, but for right now, the focus of our attention for the next 5 years lies in these NCDs that are being shown on the screen. You can move on next. Again, when it comes to risk factors, globally we have 5 main risk factors that the global community takes importance. That is tobacco use, harmful use of alcohol, unhealthy diets, physical inactivity, indoor air pollution. But we say because of the type of environment we live in as Kenyans, we need to address these 2 additional risk factors. And that is the exposure to environmental pollutants and toxins, and also stress. So these are additional risk factors we will be addressing in this strategic plan. Next. Now to the gist of the matter. So for our strategic plan, we organized it into pillars, and each pillar has strategies and activities in it, and also objectives. So we have 5 of them, and we try to look at both what is recommended globally and what is also our national priorities. So if I can just go in order, our first one being sectoral and multi-sectoral coordination and governance. So in here, we emphasize the issue of working with sectors outside health. We know most of the drivers, most of the NCD risk factors. In order to tackle them, we need the help of outside people who work outside the health sector. For example, we need transport, we need agriculture, we need trade, and all that. So we laid very key emphasis on our working with them. Also, when we come back to the health sector, we need to reach out to our other colleagues who are in HIV, in reproductive health, in the spirit of integration. So this is what the first pillar tries to address about. And also to ensure that we have accountability when it comes to NCD programming, both at county and national level. Pillar 2 talks about minimizing exposure to modifiable risk factors. Among the things we prioritize here is the issue of legislation. Again, with the issue of risk factors, we need key legislations. So for this, we prioritize for the legislations that are already existing. For example, tobacco control law, alcoholics drink law. There is need to further, first of all, amend them in view of the changes that we're experiencing with the risk factor profile. And 2, enforcement still remains a huge challenge for this legislation. So those are some of the things we prioritize. Number 2 is prioritize the issue of health promotion and working with the community and schools. So we need to empower the communities to be able to be knowledgeable how to prevent these diseases. We also need to take advantage of the space and mold our young ones when they are still in school. So that's why we want to entrench NCDs prevention in the school curricula. And lastly, the workplace. Majority of people in their middle age spend a lot of time at workplaces. So we want to also drive the NCD agenda at workplaces. And lastly, moving away from population level intervention, we also want to look at the individuals themselves. And here we prioritize the issue of vaccination. For example, the HPV vaccine for adolescent girls. And we've also prioritized other vaccinations that are important to persons who live with NCDs. For example, the COVID-19 vaccination. I'll move on to the next pillar, which is on health systems response and management. As I alluded before, last time we didn't pay close attention to management of NCDs, but this time we prioritized it. Among the things that we've emphasized is the issue of primary health care and integration with UHC. We also realized that health capacity or health workforce for NCD is not very strong, so we want to ensure both at levels, pre-service and in-service, and also for specialists that they are well able to manage NCDs at hospitals. Another ailing factor is the issue of the supply chain. So for this pillar, we say that we want to ensure that the issues of access to medicines, the issue of quality of medicines is well addressed. Another area is quality improvement. So as the healthcare worker is managing patients at the health facility, there's need to guide them using guidelines and also ensure that they are improving the quality of the care that they're offering. So it also deals with that. Another aspect in this pillar is the issue of infrastructure. We have cancer centers, we have regional centers so far, and also comprehensive centers. But these are not enough. And we also have to bring on board other diseases so that we have centers of excellence, which are quite a bit infrastructure heavy and also human resource heavy. But I think the way to go is we want to stop that Nairobi being the only place where most of the specialists are, or where people have to travel far to reach to get services. So one of the areas we've tried to prioritize is the issue of trying to have regional centers of excellence where patients can seek NCD treatment. And lastly, within that pillar, taking into cognizance what we've learned with the COVID-19 pandemic, we've realized that there's disruptions of services that are occasioned when such pandemics occurs. So we've also prioritized the management of NCDs during emergency situations. The fourth pillar deals with advocacy, communication, and social mobilization. So here we mainly want to have a very robust monitoring and evaluation plan, which takes into cognizance the major diseases, and we've aligned our target with the global target. So at least we have 14 key indicators we'll be monitoring, but we also have an additional 8 low-key indicators that we will also be monitoring. You can move ahead. So the chapter 6 deals with resource requirements. Previously, as the two speakers said, strategy was not costed. But this time we indeed did cost it, and we used activity-based costing methods, and this is where the consultant, Dr. Mwai, was very instrumental in helping us do. So for the activity-based costing, this is a process that allocates cost of inputs based on each activity, and then it tries to identify what causes the cost to change, and activities are traced to the products or services which the activities are performed. We can move on. So this is the total cost that will be required to implement the strategic plan. I think you can look at what the figure that is eclipsed down there. So for the 5 years, we need a total of 377 billion to implement this strategic plan. The heaviest, around 95%, will be taken on the pillar that deals with health systems response. Remember, that's the one that deals with infrastructure and all that, so it's taking around 95% of all the costs. And then for the yearly costs, it gradually increases, but it ranges around 70 billion for all the activities. Next, please. For this slide, we are hopeful. Currently, we try to look at the resources we have. Out of the 370 billion, we are assured of 20 billion, but we are hopeful. We are hopeful that within the 5 years, the other deficit that is 94%, we shall have a way of Dr. Jenga is laughing. Dr. Jenga, we're in it together. We know we will get the rest. We have goodwill. We shall have the deficit of 94%. We can move on. Our last chapter deals with institutional framework. So in this chapter, we've tried to move on again. Thank you, Anne. So for this chapter, we try to look at the individuals or organizations that are important in the implementation of this strategic plan. We have laid down what each organization has to do in order for us to achieve our goal. So we have, for example, lawmakers, we have the county governments, and we have spelled for them what they need to do for us to achieve. We also have something that needs to be done by the individuals and communities for us to implement this strategic plan. So that chapter deals with the institutional framework. Next, please. Just to acknowledge some of our partners who have been working with us today, and we say asanteni sana. Next, please. So today we are also launching another document that is the organization of trauma framework. Injuries, as I said, also a large contributor to mortality in the country. And what this framework will do is try to spell down what is needed for provision of trauma services at each level, from community to secondary level and also to tertiary level, so that the quality of care that is offered to patients who have trauma is improved. So it also talks about the pre-hospital services, what is done before they arrive at the facilities, and when they go to the hospitals, what type of equipment needs to be there, what type of specialist needs to be there, so that this patient who has trauma is able to be managed well. I think this should be the last slide. Next. Thank you very much for listening to me. Thank you.
Thank you very much, Dr. Gadesha, for that very nice overview. At least we can see where we are, and we have seen what we want to do. And Madam CS, we really have a lot of work ahead of us. We want to change the tide in the next 5 years. We are trusting that by the time we do our mid-evaluation, we shall have achieved most of the things that have been laid in the strategic plan. Thank you very much. I want to hand over the program to Dr. Mare to continue from this juncture. Thank you very much.
Once again, thank you very much, Anne. And I also want to take this opportunity also to thank Gladwell for taking us through the strategic plan, giving a very good narrative in summary form. I think now we are all expert on the strategic plan. Having said that, our chief guests, Dr. Mercy Mwangangi, We now want to move to the next part of this program. And in the next part, we are going to call upon a few partners on behalf of the others to make speeches. But before we do that, allow me to recognize the presence of a representative from Mombasa County who has joined us. He may have stepped out. I'm also informed that we have Nyamira. Oh, thank you. Yes, Nyamira County. Oh, karibu sana. And Migori. Okay. Karibuni sana na asante. So, our chief guests, as we have heard, we are Department of Hope. Yeah. Looking at the deficit we have, I want to believe we are equal to that task, and we should be able to mobilize resources and get there. Just like we were able to develop the documents we are launching today. Yeah, it was through hope and determination that we are able to be where we are today. So I want to call upon the representatives of other partners who we have been working with, particularly toward development of this document. And it is my humble pleasure to invite Madam Caroline Jogona, for the country path director, to come and give our remarks. Karibu sana, Madam Caroline Jogona.
Madam Chief Administrative Secretary of Health, Dr. Mercy Mwangangi, Director, Directorate of Medical Services and Preventive and Promotive Health, Dr. Andrew Mulwa, Co-Chair, NCD, ICC, Dr. Eva Jenga, County Executive Committee members, WHO, health partners present, ladies and gentlemen, good morning. Allow me to say as PATH, we are truly delighted to have contributed and participated in the development of this NCD strategy of 2021-22 to 2025-26. Our mission as an organization is to advance health equity through innovation and partnership, with one of our strategic priorities being increased health system capacity and resilience. Now, we realize this with partnering with governments and like-minded organizations aimed to increase capacity, realize equitable and accessible quality care. Now, when I look at the representation today in the room, I believe we can truly and confidently say that the spirit of innovation and partnership has truly been reflected throughout the strategy development process. And I believe it is critical that we maintain this partnership and collaboration even for the implementation of this strategy. I got really excited when I looked at the banner here and I saw multi-sectorial approach. That is the spirit that we truly need to embed and integrate moving forward. Now, the launch of this NCD strategy is a significant and huge milestone in the NCD response for the country, as it clearly defines a roadmap for NCD interventions for the next 5 years. It is therefore a critical planning, budgeting, coordination, and advocacy tool across both the national and county government, as well as NCD stakeholders. As it's been mentioned before, it's a follow-up from the previous NCD strategy of 2015-2020. Now, Dr. Gladwell has, beautifully taken us through the strategy, and she did mention that this new strategy aims to sustain the gains that were made in the first strategy, so we are not really reinventing the wheel. However, it's also seeking to accelerate the NCD response and align that with emerging public health threats such as NCD in pandemics, and I believe COVID has really amplified that, and largely seeing the greater digital health utilization to support care, monitoring, and reporting. Now, the strategy comes at a really timely time for us as a country. From the statistics that have been shared here, the NCD burden and economic burden is quite huge in this country. We've seen that 42% of all hospitalization are NCD related and up to 39% of mortality. That is huge. We cannot ignore that. Now, this strategy seeks to stem that rise through a holistic approach that entails strengthening coordination and governance, risk factor mitigation, improving access through primary healthcare and community health services, NCD commodity security, capacity building of human resources for health, advocacy and awareness creation, and lastly, strengthening data and systems as well as research. What I like about this strategy, it has a robust monitoring and evaluation framework, which has clear targets, roles, responsibilities, and timelines to ensure accountability in its implementation. I think it's been mentioned here that the document is now costed. That enhances evidence-based planning and resource mobilization. As an organization, like I mentioned, we are delighted to be a strategic partner in the prevention and control of NCDs in Kenya. And how we've done this, we've provided technical, logistical, as well as financial support to both the Ministry of Health at the national level, as well as at the county level. Now, the support that has passed we've availed so far has included facilitating the review of the previous NCD strategy. We were quite instrumental in that. That has then informed the strategy that we shall be launching today. We've also partnered in writing workshops, facilitated government in a wide range of health domains. Allow me to mention a few. We've worked in the space of HIV, TB, malaria, reproductive health. We've not been left behind in the fight against COVID. We've actually supported the ministry in COVID response. We are also working on primary healthcare. We've been instrumental in vaccine development and introduction, early childhood development, as well as NCD. Now, worth noting, since 2006, as an organization, we've invested over 210 million USD in the health sector in this country. We look forward to continued collaboration with the government as well as other stakeholders. Now, in this NCD space, as PATH, we have 4 areas of focus. Now, the first area is supply chain, for supply chain strengthening to ensure improved availability and access to NCD medicines and other related health commodities. The second area of focus for us as an organization is integrating and decentralizing NCD care to primary health care. Now, the third area of focus for us as an organization is improving NCD data management systems to inform high-quality NCD data for decision making. We say as an organization, we believe in quality data for decision making, and I'm truly excited to see that this has been embedded even in this strategy. Worth noting, we've not done this in isolation. We've done this in partnership with Access Accelerated as well as other partners. Now, the last area of focus for us as an organization, PATH is also supporting the co-packaging solutions to improve access to the products needed for diabetes self-care, as well as integrating hypertension and into other established chronic care structures, particularly HIV. Allow me to reiterate that as PATH, we shall continue supporting the ministry as well as the county levels for dissemination and implementation of the NCD strategy, and particularly around the 3 areas I've mentioned of supply chain strengthening, integration and decentralization, NCD services at the primary healthcare framework, NCD data system strengthening, and HIV NCD integration. As an organization, we are working with the Ministry of Health, specifically the Department of NCD, as well as NCD ICC, to develop an electronic dashboard that leverages on the NCD Navigator tool to monitor the NCD strategy implementation. We will continue being a strong technical partner to the Ministry of Health and the NCD fraternity, and we will work to ensure that the NCD prevention and control aspirations are met. Thank you, and we believe that this is the journey of true partnership and collaboration, and we are happy to be part and parcel of that. Asante sana.
Thank you very much, Madam Caroline. I'm also advised now there is a new way of appreciating our presenters, and that is COVID clap. And COVID clap, you just wave like this, huh? You don't, we have to be COVID compliant. That is what I've just been advised. So can we maybe start by appreciating Madam Caroline Juguna with the COVID club. Asante sana. Thank you very much for that very stimulating speech. We now come, we are now going to call upon Dr. Zipporah Ali. Dr. Zipporah Ali is the Chair, NCD Alliance. You are most welcome, Dr. Ali, to give your remarks. I know you are representing many organizations, some amongst us here like MSF, Meditronics, and the KCS. So, Karibu. I'm sure this is also your, is it called the first speech? Yeah, thank you very much. Let me just get this way.
Thank you very much. Distinguished guests, Dr. Mwangagi, Chief Administrative Secretary, Ministry of Health, Dr. Andrew Mulwa, Directorate of Medical Services, Preventive and Promotive Health, Dr. Ivan Jenga, whom you all know very well, Chair of the ICC Coordinating Committee, former Chair of the NCD Alliance. I just took over her, so I'm a bit nervous that I will not be able to represent her very well. Dr. Joyce Nato, WHO office, Kenya office, and of course, not forgetting Carol, who has just spoken very well. Thank you, Carol. And Dr. Maria, we keep on forgetting to mention you and your team. I think you're very important. You took the lead in developing this document. On behalf of the NCD Alliance, I want to say thank you very much for inviting us, but I also want to say we need to recognize the people living with NCDs in this room and in this country, because this is about them today. It's about people living with NCDs, myself being one of them. So I don't think very few of us here probably have never had an NCD or do not know anybody with an NCD. If you are to ask, do you have an NCD? A number of us will get up. Do you know anybody with an NCD in your family? Most of us will get up. Do you have a neighbor? By the end of my questions, there will be nobody sitting, so I won't go into those questions. But I really want to say thank you very much for inviting us to be part of this event. NCD Alliance has been very active in developing this document, including supporting people living with NCDs to attend the workshop that was done in Naivasha some time back to develop the strategy. So thank you very much for that recognition. Now, NCD Alliance is the umbrella body of all those organizations working in terms of advocacy for prevention, treatment, rehabilitation, survivorship, palliative care on NCDs. So our focus is on advocacy across the continuum of care for NCDs. And this includes patient-led organizations, NGOs, civil society, CBOs, community-based organizations are very important, and also includes professional associations that are actually addressing the burden of NCDs. So we do have a number of members, and some of them are in this room today. I want to say thank you to them. Our vision is the same vision as the Ministry of Health and NCD-free Kenya, and I think most of us in this room are actually hoping that one day we'll have a country that has no NCDs, so that we don't have many people who are sick and suffering from these illnesses. As I talk about our objectives, I will advocate for access to rehabilitative and palliative care for persons living with NCDs. I think you know that an illness is not just the physical symptoms, but there are other things that are also very important, the psychosocial aspect of care. And this is one of the things I found when I was interviewing people. They talked about the fact that nobody understands our illness. At place of work, nobody understands what we are going through. At home, our families don't know how to support us. The community doesn't know how to support us. When I'm sick, somebody who actually had a sleeping disorder talked about the fact that when she goes into a matatu and falls asleep, people make fun of her. Sometimes she misses her stop. People don't know what sleeping disorders are, including healthcare professionals. We don't understand some of these NCDs, and we're not able to support our patients. So there's a lot of need in terms of educating healthcare workers to understand, especially the neglected small NCDs. And I don't want to call them small because for that person, that's a big problem. The person going through that disease, it's a big problem for them. And I saw the list that Dr. Gasheka shared. We need to also be inclusive of those other NCDs. So we also advocate for affordable, safe, and healthy, nutritious food. Again, during the interviews I conducted, most people complain that they are given these diets, which are quite expensive. Where do they get the money to buy these nutritious food they're being told to buy? Diabetic patients are told eat 1, 2, 3, and those things are quite expensive for them. How do they afford that diet? So we need to look at even control of of food prices in the market to help these people. So engage national and county governments on NCD policy and legislative issues, including universal health coverage. Again, we do not understand what our UHC package is for NCDs. It would be good if we could understand what is included in that package, if NHI is covering the essential medicines for NCDs as well. And of course, Carol talked about working together in terms of NCDs. I think we need to work together because looking at the deficit that Gladwell shared of 94 billion shillings, we need to all come together to put our efforts together, not just technically, but financially, to be able to support the government to address the burden of NCDs. So the other thing we do is our role in prevention and control of NCDs is advocating to raise awareness on NCDs, and that's what we do most of the time. And then to promote interventions, reduce shared risk factors for NCDs, like tobacco, unhealthy diets, physical activity, inactivity, harmful use of alcohol and air pollution. And of course, advocate for health system strengthening. And I think when you actually put in place systems to address NCDs from prevention to rehabilitation, you actually strengthen the healthcare system in many ways. So we need to also advocate for healthcare system strengthening to ensure adequate access to NCD prevention and control, and of course to respond to health needs for people living with NCDs. And I think you know that in the recent years we've been talking about the movement of people living with NCDs. Nothing about us without us. Meaningful involvement of people living with NCDs in everything that we do. And that's why the NCD Alliance actually supported a group of people to go to Naivasha to be able to put what they want into this document. So we need to have the presence of these people in this document, not just at the planning level, but also at the implementation level, and also at the level of accountability, monitoring and evaluation. Sorry, I'm shaking a lot because I think it's first time to stand here talking to this team. I talk a lot in public forums, including even WHO, but being a chair of the NCD Alliance and the other chair looking at me, I'm a bit nervous. So, Eva, you need to look the other side. Thank you. Yeah, so what we have been doing also is building the capacity of people living in the NCDs. And NCD Alliance has done a lot of advocacy workshops in the past 2 years. We were doing them physically, then COVID came, and we've been doing them again virtually to make sure that people understand how they can address their issues, how they can talk about their needs. And some of them are in this room, I can see a number of them here. They are really very, very good advocates. They can speak at a very high level of meeting about their needs. And in 2018, the NCD Alliance actually held a meeting for 2 days for people living with the NCDs. And out of this meeting, we came up with a document on meaningful involvement of advocacy agenda for people living with the NCDs. And there are quite a number of issues that were addressed in the agenda. So you can actually find it on our website and read about it. So one of the other things we do also is advocate for a budget for NCDs. And again, even with the deficits, I'm sure we'll be able to work together to address issues of the budget. So I've talked about the meaningful involvement of people and accountability. We hold people accountable. We want to hold the ministry accountable for what they have put in this document. We'll be watching you, and we will not just be watching you, but we'll work closely with you so that we actually have a successful implementation of the document. So you can find us on social media. We are very active on Twitter, Facebook, and other platforms. Thank you very much. Sorry that I...
Thank you very much, Dr. Zipporah Ali. I want to assure you, you have done extremely well. Very well indeed. I would give you an A. So, can we appreciate Dr. Zipporah Ali? Thank you very much. I know after Dr. Zipporah Ali, we are supposed to have somebody living with NCD talk to us, but we shall try to create time for that. I'm informed that we are having a ministerial top management meeting at 10, and some of us, particularly Dr. Mulwa, is required there by 10:15, so I'll kindly request those who are giving speech after this to be a bit shorter so that we are within the time. And therefore, starting with myself, now I want to be very short. I want to call upon the chair of NCD ICC, Dr. Eva Jenga, the outgoing, is it chair NCDAC? Now I'm sure Dr. Zipora, you can revenge and look at her. Thank you. Karibu sana.
Asante sana. Good morning, all. Our chief guest, Dr. Masi, my friend, and Dr. Murwa, whom I've been dealing with at different levels, and now I'm telling him I'm so happy to sit next to him. Caroline, we talked before as we killed time to wait for Masi and Murwa. We had quite a good discussion. WHO, NATO, all protocols observed, all the county CECs, and of course, most important, people living with NCDs in this meeting and also online, our media. The media, really, you are the ones that really I would like to acknowledge a lot as one of our partners that will help us in this. I want to say thank you very much, everybody. I want to appreciate Dr. Gadesha. Dr. Mare, let me appreciate Dr. Gadesha before I appreciate you. Because in the previous strategic plan, 2015, Dr. Gadesha was very young in the NCD, but she was there steering with Dr. Kibasho the first strategy, the strategic plan. And you've seen our gaps, our strengths, and our challenges, and where we were weakest. And this is why you being in this strategic plan really has made this a really very involved, comprehensive document. So, Dr. Gadesha, a special thank you to you. I want to thank Elizabeth, who has joined the NCD department, and I know you work very well with your head, Dr. Mare, whom I have known for a long time and who really has shown the passion. And Anne, thank you so much. You really did a good job introducing all of us to start with. And I know the work you are doing also in that to support the NCDs. I want to thank NCD Alliance, Kenya. Zipora, you never need to shake. This was your best maiden speech, and I think you continue like this. I think NCD is going to go even to higher heights. So well done, and I know we are together in this. I'm not going anywhere. So even as if I look at you, don't worry, I'm still with you. I want to just highlight what is this NCD-ICC, because now here I'll stop being on the society side, and I just let you highlight why are we talking about multi-sectoral approach. I think in 2015, and even before that, it's just that we didn't talk about it. The people who are passionate and who really want to see changes in the NCD space, we realized and we embraced that there's no way we can domicile the approach and management of NCDs and even communicable diseases in the Ministry of Health. So, our chief guest, if we don't involve other players and other stakeholders, we will be actively wiping the floor when we leave the taps open. And that's what sometimes we tend to do. So this is what, in 2018, the Ministry of Health came up with the creation of the NCD Intersectoral Coordinating Committee. That committee is actually chaired by the Director General of Health. I just happened to co-chair because I'm in the NCD Alliance. We were the first people that helped create this. That NCD-ICC is made up of several technical working groups. In fact, at one point, the technical working groups were so many. There were about over 10. But I can tell you to date, we have about 7 or 5. I can tell you which ones are very active. We have the ones that deal with diabetes. I start with that for being selfish. I'm a diabetes specialist. So the technical working group in diabetes have continued to be active and give reports to the NCD-ICC committee. The one on advocacy, again, is shared by NCD Alliance. It's been very active. We have a very active one shared by Dr. Mare and his team, the one that deals with research, resource mobilization, and where PATH has been quite active. I must mention here that PATH has really been supportive in the various technical working groups. So we have the ones that are dealing with cancer, which have been very active, cardiovascular disease, and tobacco. but we still have a long way to go, Dr. Radesha. We need maybe to bring all these technical working groups together again and restructure them to fit the pillars that you have come up with in this new strategic plan. What were the gains that we got from the NCD-ICC? That this development of the NCD strategic plan actually has had a lot of input from the active technical working groups, and we gained 5 non-health actors. So we need, Dr. Mase Mwagagi, we need more non-health actors. We were able to get treasury and finance, so even as we were laughing at Gradwell about the 6% budget that we have and the 94 that we need, since we have the treasury and finance in this group for NCD's technical working groups, I think they will appreciate the need to put a little bit more money in the NCD's department. As when we started the NCD department, because although I've never been employed by MOH, I've always been on the sideline supporting. When that department was started a long, long time ago, the budget, I can still remember clearly, it was 500,000 Kenya shillings. That's what the department used to get. That was not even enough to get paperwork in the office. They didn't even have a specific office. We slowly got a desk in the ministry, then we slowly got a division. Now we are at a departmental level. So there's growth. So even that 94%, Dr. Radesha, that's missing, I was laughing, yes, it's good to have hope, and all dreams are varied. Even this one, we shall get somewhere, okay? And then we looked in the education ministry, because we believe that if we introduce the risk factors and education at the primary level, at the secondary level, at all levels of education, that's how we'll be able to achieve prevention of NCDs. So get people to know as early as possible. So we have education in a number of our technical working groups. And then we have gender. Why gender is so key? Because as you said, you kept on talking about how the women now in smoking are picking up, maybe even in alcohol, in other NCDs. We need to find out what is really happening. So gender being involved, and also in violence, we know women seem to suffer a little bit more than our male counterparts. Then interior coordination and industrialization. The industry is so key. When we talk about diet, yes, we may talk about the healthy diet, but the way the industry is so powerful in what they propagate in the media is so key. And actually, one of the technical working groups that where we need involvement, we need media in our technical work, and they empower themselves and cater and be responsible for their health. So I want to say that I'm really grateful to be here, very proud of the department of NCD in the Ministry of Health and what we have achieved. I just pray that, like so many documents that we have developed, that they will not gather dust at the Ministry of Health, that we shall move and implement, and Zipporah, that you hold them accountable, keep on reminding them what happened. If Dr. Mare doesn't deliver, it's, of course, I'm not going to remove myself there because being a co-chair, very soon we'll get new co-chairs, but I think every one of us, whether you hold a position or not, it is our responsibility to make sure that this strategic plan works. So with those very many remarks, thank you very much, and I look forward to seeing this document work. Thank you.
We appreciate that. Then the COVID way, eh? Thank you. Thank you very much, Dr. Eva Njenga. We have heard you and heard you very well. Thank you for that speech. Now we call upon Dr. Josephat Mbai, CECM Muranga County. I'm also informed he's now the chair. He has taken over from Dr. Andrew Mulwa, who is our head of the directorate. So, welcome, Dr. Mbai, and congratulations on your new, was it an elective or appointed? Thank you very much. Elected. Elected, yes. Yeah, we wish you all well and hope you'll follow Dr. Mulo.
Thank you very much, Dr. Mare. The chief guest, Dr. Masi Mwangangi, our CAS, all protocols observed. In the interest of time, I don't want to say much. I just want to reiterate our commitment as the counties that this discussion of NCDs is very critical to us because we are the people where the rubber meets the road. I want to recognize the presence of all the counties here, kindly. If you come from the counties, I have heard Migori, Nyeri, kindly be upstanding. Nakuru, can we see? Yeah, that is the team that is represented here today in this national discussion of non-communicable diseases. I must say that you can be seated. I must say that Dr. Mare, I'm very delighted because when you are doing a national strategy and you call the counties, we feel honored and we feel that we are involved in this discussion. And there's one critical aspect when it comes to strategy, which is called ownership. If you don't have ownership, there's no strategy that will move anywhere. Because the implementers must be aware of what are the things that are being discussed right from the inception. And I've listened to different presenters talk about NCDs, and we in the counties have also done quite a bit. I'm sure majority of us are doing a lot of screening. We have had renal dialysis units put in quite a number of hospitals in the counties. I don't think there's a county that right now doesn't have a renal unit where dialysis is happening. But that doesn't come without some challenges. As counties have seen quite a number of increase in NCDs, especially hypertension, diabetes, and sometimes it becomes difficult to cope, especially when it comes to the issue that was raised by Dr. Eva Jenga and Dr. Ali of commodities for diabetes and hypertension, especially when it comes to the issues of cost. The other challenge is lean trained staff. Many counties, actually majority of them do not have nephrologists, yet they have dialysis units. So you can see there goes a challenge. And then we have had COVID-19 pandemic that has given us very poor outcomes in terms of how we are managing our NCDs, because suddenly we focused on COVID and we forgot many other diseases. And I must say that if you look even at the mortality of COVID-19 compared to NCDs, it's something which you can't even say. The numbers are quite far different. Yet we put a lot of emphasis on COVID. And when I say this, I'm looking at next year. And I'm looking at, where politics take precedence, especially during transitional period like now. And I'm asking myself, we are launching this strategy right now, and God forbid, I don't know whether this leadership will be there tomorrow, including myself, when we are continuing. But I want to say this, Dr. Mare, because we have the technical people who are there, who can have the memory institution, who can actually forge this strategy forward. How I pray that the political changeover will not affect this, so that we have a matrix of implementation that is so clear that it doesn't matter who comes on board in terms of leadership, that we still achieve this. Because that is normally a very serious backdrop. And I want to request the leadership in the counties who are here, CC, Nakuru, Migori, and the rest. When we go back, let us discuss this NCD issue with our directors and the technical people and the focal persons in the counties, so that even if we were to exit, then there's somebody to look at that. Then we also need to do a lot of screening. And we can even train our community health volunteers. I think, Dr. Mulwa, you'll agree with me that in preventive promoting, we can use the community health volunteers. We train them to do screening for us, so that we also train them on referral mechanisms where they can refer to a facility, and they can also be trained to teach communities on health, diet, lifestyles. For us in Mount Kenya region, I know Nyeri and Murang'a, we could be leading in the country in terms of NCDs. We have our fair share of that, and we really need to concentrate in terms of creating awareness. Then at the hospital, we really need to make NCD drugs, especially for diabetes and hypertension, free or heavily subsidized. One of the things I've noted in Murang'a, when I go to the MOPC clinic where doctors are seeing hypertensive and diabetic patients, is that you find very old Kenyans, elderly women, elderly men, who will go get a prescription, walk to the pharmacy, and when that prescription is written OS for 2 products, if you look at the face of that elderly woman or man walking away from the pharmacy going home, your guess can be as good as mine that they are not going to buy those drugs because they don't have the money. And this is true even for other counties. Then the other thing would be strengthen laboratories right from the dispensaries to screen diabetes, hypertension, and some cancers like cervix, prostate, and all that. When people do medical camps, I always see them saying that we are going to screen cervix, we are going to screen this. This can be done at the dispensary if we really invest in that. Then we need to train and retain health workers on NCD screening, diagnosis, and treatment, and strengthen all county hospitals to offer oncology services adequately by putting in drugs, machines, and personnel. One of the challenges I've seen in the counties is that every county now suddenly wants to do a cancer center because probably it could be a good political move. But I want to say this. As we develop this strategy, Dr. Mare and Madam Kase, we really need to look at how do we harmonize our resources so that we don't have counties who are neighbors doing the same thing. Because if I do a cancer center in Murang'a, it will not make sense for Nyeri and Kirinyaga to do the same. Maybe we could have regional hubs. And when it also comes to specialists, do we really want to have 10 oncologists in Mount Kenya region while Lake region doesn't have? So those are some of the things that we really need to look at. Now, the final aspect I want to talk about is on precipitating factors that cause cancer. Tobacco being one of them. We have a law that bans smoking in public. I remember I banned smoking in public in Murang'a County, and I got a very serious backlash even from tobacco manufacturers. And people felt that it's like I'm becoming too much in terms of increasing on personal issue. But as a government, we really need to be firm. Whatever laws are supporting us to prevent people from getting sick, let us implement them. Number 2, we have the agricultural inputs. People are still using some carcinogenic chemicals in the farms, and we are not doing anything about it. The other day we were developing an AMR strategy and antimicrobial resistance, and we were saying we need to work together with veterinary doctors and livestock people and agricultural people to make sure that we know what chemicals are being used in our chambers, in our farms. We eat a lot of chicken, we eat a lot of pork, but are we aware what the farmers are giving those that can affect us that are carcinogenic? So those are some of the discussions. And we have a lot of things we can share. Dr. Thank you very much for that presentation. Involve us in the counties, and this will succeed. It will succeed. Thank you very much, and God bless all of you.
And we appreciate Dr. Mar, very able chair of the CEC's forum, and for